Hello, and welcome to Child and Adolescent Psychiatry Grand Rounds. We're grateful to be partnered with the Faculty of Medicine and Dentistry Office of Lifelong Learning and the Physician Learning Program. Um, and we'll like to do the acknowledgement. The University of Alberta, its buildings, labs, and research stations are primarily located on the territory of the Nehio or Cree, Niitsi Tape or Blackfoot, Métis, Nakota or Stoney, Dene, Haudenosaunee or Iroquois, and Anishinaabe or Ojibwe Saulteaux lands that are now known as part of Treaty 6, 7, and 8 and homeland of the Métis. The University of Alberta represents the sovereignty, lands, histories, languages, knowledge systems, and cultures of all First Nations, Métis, and Inuit nations. So please use the chat feature if you have a question about technical issues. And if you have a question for our speakers, please use the Q&A feature. And we will have the option for live questions as well. So you can just put up your hand and we can unmute you. So I'd like to introduce our speakers. We're very excited for this presentation that makes therapy accessible for those on the spectrum. So Dr. Cammuso, Lichtenstein, and Nab Inns are PhD psychologists in Bradley Hospital's Verrecchia Outpatient Clinic for children with autism and developmental disabilities. And please correct me if I didn't pronounce your names correctly. They provide individual, group, and family therapy and provide training to community providers in schools and private practice settings. They also serve as clinical assistant professors in the Department of Psychiatry and Human Behavior at the Warren Alpert Medical School of Brown University, providing training and supervision to psychiatry and psychology residents and fellows. They also have a particular interest in supporting individuals with autism spectrum to facilitate learning in the classroom setting and promote engagement and change in the therapy setting. So yeah, we're very happy to have you. Now give the floor to you. I think, there we go.
Okay, I think that will be our last technical difficulty. We unmuted. Thank you for having us today. We're really pleased to be here. And thanks to Daniel Moreno de Luca for inviting us. Daniel was part of our team until a couple of years ago when he defected, and you all have the honor of working with him now, so we miss him greatly. But that's how he became familiar with our work. So we are going to talk today. Well, first I'll do my disclosures. We have no financial relationships except that Dave and I have a small grant from within the hospital to fund an RA to work on a chart review project with us. We're all employees of Brown University Health, which is the sort of parent body of Bradley Hospital. We haven't received financial support for the presentation, have no conflict of interests or financial relationships that contribute to bias. These are your learning objectives for today. We hope that you'll feel able to discuss the particular challenges in therapy for youth with ASD. And if you work with this population, you could probably already do that one. Employ at least 2 adaptations to individual therapy and identify at least 2 cognitive or behavioral factors that are associated with ASD that can affect the delivery of therapy content. So why, and I was going to give you a little intro that we in our clinic do individual, group, and family therapies. We have psychiatry services, and we also do consultation to community providers, where we've been meeting with a group of providers in the community who have private practices, and Blue Cross has been funding us to work with them for 18 months to consult around provision of services for kids with ASD in the hopes of expanding access to services for this population. So what you're getting today is a condensation of 18 months, and we promise we'll talk fast. So we are not going to talk a lot about autism itself. We're going to assume a level of baseline knowledge for all regarding characteristics of autism, but rather we're going to talk about the co-occurring conditions that bring children into therapy services or psychiatry services. So most sort of bundle under the classification of emotional or behavioral dysregulation, with externalizing conditions such as aggression, attention problems, as well as internalizing such as anxiety, depressed mood, and suicidality. And then the location can vary. School, home, or both can be affected. But sometimes kids find success in one setting versus the other, and that can give us some clues. And then a lot of, I'd say a primary concern for a lot of the kids and teens that we see are related to restricted and repetitive interests, problems with flexibility that can lead to real problems in the school environment, but at home as well, and to conditions like restricted eating. And then social problems increasingly emerge as kids approach middle school years. We tend to see a lot of mood, depression, depressive-like symptoms at least occur around that time as kids become more aware of their social vulnerability. That one's blank. Oh, this is a fancy slide. So ASD co-occurrence, we know that the rate is higher for almost all psychiatric conditions for children and teens with ASD. This is based on a 2023 study that was a meta-analysis of over 300 different articles, and you'll see a much wider range reported, really depending on how the data were collected, but ADHD tends to be the primary co-occurring disorder, anxiety a close second, and disruptive behavior disorders. As you can see, the top are all sort of diagnostic, and the bottom we've got feeding and eating and sleep-wake problems, which accompany many of the conditions above, as well as just autism itself. So families are often dealing with those issues. Intellectual disability occurs in about 35% of kids, which is kind of a flip from when I started doing this work years ago, before the dawn of Asperger's, when it was much more common for people with ASD to have intellectual disability. But now we work with many, many kids who have low average to above IQs. Interestingly, although we know that a lot more trauma occurs in this population, the rates that they found in this review were not significantly higher than the general population, which is both good news and not for anybody. Today, we're going to focus more on individual therapy. So we see the families of every child that we see in the clinic, even if the focus is individual therapy. So we may meet with the child alone and then bring the families in. We haven't incorporated the family therapy, partly due to time, but also partly due to those being some more familiar skills for most clinicians. So we're focusing more on the adaptations that can be made in individual therapy and group to make kids more comfortable in the therapy setting so that they can benefit from interventions. And this cartoon illustrates that nicely. If you are able to see it, can you please shovel the ramp? All these other kids are waiting to use the stairs. When I get through, I'll shovel the ramp. If you shovel the ramp, we'll all get in. And that's true for us as well, right? These strategies work for everybody. I think anybody working with children knows that if you make the adaptations to make therapy more playful, more structured, more interesting, more visually supported, all children will do better. So we know they work for kids with ASD, and we'll talk about that in a minute, but also for kids with ID who tend to need similar supports, just have less of a research foundation on the strategies for them. And those who are typically developing neurotypical also benefit from the same strategies. Oh, so a little story. When we reopened the clinic a number of years ago, and I saw my first outpatient in a long time because I'd been in the schools. So he came in, ADHD, ASD, and was suspended from school. This little boy flipped all over my office, literally, physically, was flipping over the couch, rolling around the floor, and throwing my toys. So when the parent came in, I said, boy, this was really hard for him. We didn't get any therapy done. He's really active. And she looked at me like, duh, this is why we're bringing him. And I quickly got my act together so that by the next session, I brought along this schedule on the left that just listed what was going to happen that day in very broad terms. He was a reader. He had average intellectual skills. And so it told him the steps he'd follow and also what the expectations were for him to participate and be safe. He knew what those meant, but I always try to assess that. We also have tasks where kids can sort pictures or words into what's acceptable in the therapy situation and what's not. What are the expected behaviors? Anyway, presented this, he looked at it, and not all problems went away, but more than 75%. It organized him. It provided scaffolding for him to understand and be able to predict what would happen next. So I would say we all use a visual support to illustrate the schedule, whether it's in writing or pictures. We all know it. They know it every time, and it never gets old in terms of its usefulness. We'll pull today from two primary sources of information. The first group to do a wide-scale review was National Autism Center, and then that was followed up by National Professional Development Center. So the most recent is in 2020. Findings of both groups were very similar, so we have confidence that they found them with different strategies of approaching their reviews. There's seven interventions that affect behavioral health, and I highlighted the top 4 because those are what we tend to use. We're not going to discuss specific curricula because those are available to all and you can follow along, but we did list them here for you. They're becoming more and more available in terms of curricula for kids with ASD that are specialized for anxiety, for executive functioning, emotional regulation, and social skills. And we use some of these in our clinic. Today, what we'll talk more about is the strategies that are associated with improvements in communication, adaptive skills, social skills, and behavioral challenges. So there's a wide array of strategies that can be used in our setting that are similar to what would be used in the educational setting to help kids understand. So that will be the focus as you hear from Dave and Christine, how to enhance your practice so that kids with developmental disabilities can participate in the outpatient treatment setting. And again, it'll be a quick skim through that. It will cover the broad categories of self-regulation, communication, and cognition. And in the interest of time, I'll skip my tour of the clinic and we'll come back to it at the end if we have time.
Great. Thanks, Karen. And thanks, everybody, for having us. I'm just noticing Karen's got that picture of that cartoon right on her office door. I didn't notice that. That's a good one. So I'm Dave Lichtenstein. I'm also a psychologist in the clinic. And I am going to be talking about interventions from a therapeutic perspective for sensory and self-regulation concerns for our clients. I'm also going to talk about communication. I'll come back to that in a second, or in a few minutes, rather. I'm mashing up sensory and self-regulation here. Not sure if that's fully scientifically sound, but just for rhetorical purposes and time considerations, I'm considering this section about things that happen in our clients' bodies that influence emotions and behaviors. Some of these, many of them, are more kind of classic autism, like sensory sensitivities. But some, like inattention or impulsivity, might sound like other conditions like ADHD, which is not surprising given the high co-occurrence that Karen mentioned earlier. So I'm just going to try to highlight a few common threads that underpin the work that we do, like visual supports, use of special interests, repetition, and increasing levels of difficulty over time. Based on my experience, I divided these supports excuse me, into 3 levels of difficulty from the clinician's point of view, moving us from things we can do to accommodate clients' needs to work on other issues, more to skills that we can teach them to cope with the actual challenges in sensory or self-regulation systems. So first is kind of the easy level. None of these are easy, but easier, which is sort of basic accommodations, things we can do in the background to try to avoid sensory concerns or hyperactivity or getting in the way of our sessions. So in our offices, we can adjust our lighting. We never use the overhead lighting pretty much. We can reduce, where possible, extraneous sounds or smells. We can also try to cover up or remove visual input that's not related, even just using the computer to highlight text that you want to make sure the client is seeing, and they can get easily distracted otherwise. We also provide fidgets proactively, as you can see in the picture, to help kids sit and also to help keep them from touching things we don't want them to touch. Sometimes if someone is grabbing at stuff in my office, if I put something in their hands that they can touch, then I've solved that problem. We also do things in small chunks or short sessions, giving breaks as needed, and using visual timers to help kids understand that this time will not last forever, even though we know it's a lot of fun and they would want it to. But sometimes the self-regulation issues, though, are not tangential. They're central to the problem bringing the youth to therapy. And in these situations, we might need to teach or target skills to manage these more actively. So I've put this at kind of a medium level of difficulty. Starting with interoception, which is sort of the awareness of physical or internal sensations, what's happening in my body. I want to highlight one resource is the Department of Education in the government of South Australia created a ready-to-learn interoception kit that is full of activities moving from very basic interoception, like feeling temperature or muscles, to more complex, like breathing or feelings. So it's a great resource. I've grouped emotion recognition, speaking of feelings, into 2 buckets, which I'm calling static and dynamic. That's kind of something I made up, though, so but just a way of organizing the material. Static emotion recognition is like the classic, I'm happy, sad, worried, or recognizing how somebody else feels. Dynamic is more about recognizing emotions in the moment and how they might change. And I'll show some examples in a sec. I also wanted to mention here mindfulness, which has a lot of research support, and I do regularly include it in therapy sessions. I adapt it for a kid's developmental level by making it short and more concrete. For instance, I ask kids to count the number of times you hear me ring a bell in 1 minute, or count the number of times you take a breath in a minute, and just to kind of put it at a level that they can digest. Together with self-monitoring, these interventions can help teach kids to be more aware and be less governed by impulses or disruptive sensory experiences. So on the static emotion recognition front, here's one example of taking a youth's special interests, which in this case were one-eyed ghosts, which I could only find 2-eyed ghosts, but he rolled with that, to teach some basic feeling recognition, right? How does the ghost feel? After we worked on the ghosts for a little while, we later moved on to looking at pictures of real people, and from there, looking at myself or his dad making faces at him and him trying to figure out how we were feeling based on those. He's gotten good, actually, at recognizing others' emotions. This kid still says he is happy 100% of the time, no matter what his face might be showing. So I would be very jealous of him if I really believed that's how he was feeling. But anyway, there's many examples of static emotion recognition programs. The zones of regulation is a popular one, just one that I found I can't use because I'm not very good with colors. But anyway. Moving on to more dynamic emotion recognition, we have the 5-point scale. And I use the 5-point scale in session a lot. I like that it teaches kids the idea that feelings can move up and down in intensity and don't have to be black or white. This one includes a youth special interest in Superman, and also includes not only feelings, but also some basic coping strategies like taking a break or taking some deep breaths. So we're really teaching multiple things at once with this, and I'll come back to how in a minute. Recognizing positive emotions is also an important part of mood and self-regulation. I often ask kids to tell me good things that happened since I last saw them, and they are often pretty bad at telling me that. It's a surprisingly hard question to answer. So one way I tried to get at that was with a preteen that I'm working with. I broke the question into 2 parts, something that made you happy and something that you are proud of, or in this case, quowed of, for the quacking duck. And I just incorporated some engaging, silly animal pictures that he chose to make it more fun to look at and make it more likely that he could actually answer these questions. Self-monitoring is another way to teach interoception and better self-regulation, in this case, in the form of social awareness or impulse control. So I use self-monitoring sheets a lot to set up clear expectations at the start of a session, and then at the end of the session to ask kids how they think they did. I find that this often helps them kind of catch themselves in the moment, going off track or digressing, which I think is it's a great skill for them. It's a skill that I think is tied to mindfulness. The other advantage is that it can be a way of providing some positive reinforcement for kids doing things that might be a little difficult, like talking about emotional topics or other things. Finally, we get to the most challenging level with self-regulation. And here's where I would include taking things we've worked on in therapy or just talked about and moving them into the client's real life or real situations. So 2 ways in which I do that. One is through written scripts, which I'll show you in a second. Another is in vivo practice. And just one example recently with a 13 going on 5-year-old in my office. While discussing one of his past misbehaviors, he got agitated and he started to break things and have an angry tone. And I merely just pointed out, gosh, you look like you're getting upset. And I directed him to that 5-point scale, a different one, but a 5-point scale to kind of check in with how he was feeling. From there, that really kind of took him out of the moment in a way, and he was able to recognize that he was upset, and even better, he was able to choose a strategy, taking a break, to kind of calm down, which I think really kind of interrupted that cycle and is a great thing to practice for him. Better yet, his parents were in the room as we did that, so they could see what I was doing and try to replicate that at home with him to try to break out of these cycles of escalation. I want to briefly mention 2 other kind of more challenging sensory or self-regulation interventions that I use occasionally. One is practicing not using sensory accommodations, for instance, like taking out earplugs, maybe in my office. This is one that I wanted to put out there. I only really do this with the right kid in the right situation who I really feel like is ready for it, but it is something to think about. And then the other one is detecting sensory concerns in non-speaking kids, which again is a challenge, but also could be really important. And that might be a situation where we're really looking for, we're looking for patterns in, let's say, too much light or too much noise or overstimulation that might be inducing some challenging behaviors. So looking broadly again at self-regulation, I mentioned using scripts, and this is one that I use to help generalize some behavior beyond the therapy office. So an 11-year-old I was working with was having great difficulty safely playing with his sisters, but he really wanted their company. So using the Unstuck and On Target program, I borrowed their goal, plan, do, check script that you can see peppered in here. And we wrote out a plan for playing a game that focused on these strategies. And then I asked parents to read this script both to the kid and to his siblings before they played together. All right, so we've talked a little bit about sensory and self-regulation challenges. Now let's look at communication challenges. And that includes really 3 areas: expressive language, receptive language, and social communication or pragmatics. So how do we deal with those? Looking at receptive languages first, receptive language challenges first. Sometimes these are hard to see. I often have parents of youth with intellectual disability or who are minimally speaking, or sometimes who talk a lot. The parents tell me their child understands everything they say. Sometimes that's true, but not always. So in these cases, I'm lucky if I have a speech-language eval to give me a reading on how strong a child's language is. But sometimes I have to test things out informally for myself, maybe by checking to see how well they can follow specific directions. In these cases, I'm usually better off if I assume a child with some language concerns can't understand everything I say. And I often in these situations recommend parents use extra visuals to support the messages we're trying to convey. So a couple examples of those visuals. They can be super low tech. I think we at Varechia all love our whiteboards as a prime method of supplementing oral communication. So here's one example. The picture on the left just shows a therapy schedule that I made that's really just a series of symbols I draw on a whiteboard at the beginning of every meeting. I'm not a great drawer, but I think the youth in this case, whose agenda this was, he understood these. He was actually quite verbal, but not a good reader. So just another example, or another time when the picture schedule really makes sense. In terms of moving slightly higher tech, this time I used a computer, not a marker. And this is an example of how to practice coping strategies, in this case, deep breathing. One time I used this image, which is, again, just smelling the flower for the inhale and blowing the pinwheel for the exhale. I used this with a non-speaking child who was very afraid of having her blood drawn, which was really important for monitoring effects of her medications. We combined the deep breathing practice with this image with other pictures and video of actual blood draws to try to provide some exposure therapy for her. Next level technologically is video supports. And so the image on the left is from a YouTube video that is another example of deep breathing supports. The pufferfish gets larger and smaller as it slowly inhales and exhales. On the right, we have a video model of crossing the street safely for a child who didn't seem to monitor cars very well. And video models really can support all sorts of important adaptive skills, from hygiene skills to community safety and many other things. So just as we may need supports for helping kids understand what we're saying, we also may need to help them express themselves. And here again, we don't want to assume that they can do this capably. Patience is really the key here. Sometimes kids just need extra time and support to collect and express their thoughts. With expressive language, I also just try to incorporate other methods of communication for the kids as possible. So I welcome augmentative and assistive communication devices into my office, or AACs, although I admit they don't come in that often. But this and any other tools that I might use to communicate with a youth, I can offer them to use as well. Here's another example made by a speech-language therapist for a youth I work with. It's just a way of structuring a basic back-and-forth conversation using visuals. Often with autism or intellectual disability, the challenges are more subtle, as with pragmatic language challenges. So we can teach some skills here, like practicing inferencing or nonverbal communication. We can do that by writing social stories, or using media or pictures, or even real in vivo experiences to help kids understand what a given word, a turn of phrase, or a facial expression might actually mean. If I want to teach about rules for conversation, the Peers program from UCLA is one good source for this. They have lessons on trading information, on slipping in and out of conversation, on monitoring your audience, and even on how or when to talk about a diagnosis. And they also have a lot of video models that are really practical and useful. Last, just a quick note about humor, which I do think, along with playfulness, is really important for engaging kids of all ages and for maintaining relationships. But we do need to use it with care, and I've learned this the hard way. I often make a joke to kids who can barely last 15 to 30 minutes with me that we'll do a double session and spend hours working together. It is admittedly not my best comedic work. But for one youngster, the panicked look on his face told me not only it wasn't that he wasn't finding my joke funny, he wasn't getting the joke. And I really needed to just dispense with them that one and not make that joke anymore. So move on to better material. Let's see. One more example, and that is another example of the self-monitoring script. This one is focused on social and pragmatic language skills. And I made it to take advantage of time the youth was spending in the waiting room while I talked to his mother. So you can see here it incorporates things like asking if it's okay that you join a game or conversation, or talking about appropriate topics. And we had talked about that a little bit more prior to seeing this. So just a few examples from me, and now I will turn it over to Christine.
All right. Hello, everyone. So this is the third part and final part of our presentation today. And in this talk, I'll be addressing how to adapt cognitive therapy tools to support individuals with autism and intellectual disabilities. Hi, I hope we haven't overwhelmed you yet with too much information, but feel free to reach out to us, and we do have a Q&A session. Just want to remind you, just in case something did fly a little bit too quickly or too much information in too short a time. And so, okay. So clearly there are numerous cognitive processing styles that lead to non-functional thoughts, irrational core beliefs, and also a lack of flexibility a lot of times. So for this talk now, we identified three main areas. Needless to say, there are many other cognitive processing styles like perspective taking or memory, but we want to focus on the difficulty seeing the context. We want to focus on cognitive rigidity and then coherence. So when these are addressed in therapy, they can have a significant positive impact on the child as well as the family life. Now, in general, we encounter many kids, no matter their intellectual functioning level, who develop significant negative thought patterns. And this is not really that difficult to understand if we think about how challenging a child's life can be with being on the spectrum and what their experiences are in regards to life inside within the family, but then also on the outside. But clearly cognitive strategies, therapy tools need to be adapted in order to have effective teaching and learning. So difficulty seeing the context is basically the limited spontaneous understanding of the context, which can lead to behavior out of context. And therefore, there's great benefit in teaching these social rules and social norms. Brenda Smith-Miles, who you'll see in a minute here in one of her Tips of the Week series, she does a fantastic job in describing these unwritten rules, the assumptions and expectations that for some reason almost everyone knows without really having learned it or being taught. But she knows how this hidden curriculum is important to convey in a concrete and easy to understand manner. So I'll play that for you now. This is her tip, I believe, one of the tips, I forget the number, but she has a whole series. I'll show you this one and then another one right after.
When you're with classmates or co-workers you don't know very well, do not pick your nose, pass gas, or scratch an itch of a private body part.
All right, I wasn't sure, I hope you can hear it. It wasn't really super loud for us here, but hopefully you can hear it. Okay, here's her next tip of the week.
Welcome to the
Yeah.
Welcome to the hidden curriculum item of the week. This is a compliment almost all.
Oh great, now I missed it.
Know what body parts are.
I'm not sure if you heard it. For some reason, I caused an echo. But it was basically reminding that you can compliment people on some characteristic, but leave certain body parts out. So now, not only the low-tech approach that Brenda Smith-Mile uses, you can also use animated stories to teach kind of subtle social norms. They're very similar to social stories, but in a video format. I'll show you an example right here. And Alice, if you could give me feedback, or if this is loud enough for folks to hear.
Yeah, it's loud enough.
Thank you. All right, so this is one example. There's plenty of animated stories you can find on the internet. Just type in short story or animated story, or maybe you're even tech-oriented enough to create your own. So our next cognitive processing style that causes some challenges at times is cognitive rigidity. And that tends to invite a lot of the all or nothing thinking, the kind of tendency for some of the kids to, winning at all costs. And if I lose, that's the worst thing in the world. Seeing some of the kids always want to be first in line. but then also kind of the difficulty with transitioning, the ability to detach from one situation, shift, and then reconnect with a new situation or activity that is often influenced by a significant level of rigidity. But we also see a tendency for pretty significant perfectionism, and also that insistence on sameness that many of you probably have encountered at one time or another, when it becomes very difficult to encourage the individual to do something, even if it's just very simple, pick up your backpack or something along that line. So visual scales or thermometers teach gradations between these extremes, but then also statements like, using sometimes or a little bit can help with building nuances. These are the more subtle approaches, but then specifically teaching flexibility and more functional thinking that opens up the space from that real rigid approach of how I see the world is when you start introducing concepts like plan A, plan B, maybe sometimes even plan C or D. It could be introducing big deal, little deal as kind of a concept, because a lot of times for our kids, big deal, it seems the biggest deal in the world and everything is a big deal. Sometimes teaching that I don't have to finish something 100%. I can stop before, maybe at 50%, and actually try sometimes encouraging the parents to do that, because for them it's pretty hard too, to stop something in the middle, putting away in a designated place and then coming back to it later. But that's what teaches flexibility. Then I find it helpful in sessions to use a multiple choice question format rather than the open-ended questions. Like, how did you feel about that schedule change? It's very difficult. If you provide some scaffolding instead of that open-ended format, then it allows for reducing the stress, but also cognitively organizing it easier and better for the individual. So you could say, how do you feel about when these plans have changed? And then you give the option of, I feel calm, upset, nervous, okay, and then they can pick from that. Compromising strategies are also a great way of allowing for more flexibility, understanding that it's, it could be my way, it could be your way, or both ways. We both can be right. It could be about, maybe we do something completely different and it's not exactly what we wanted, but we still get to do something together, and both can be true for whatever the disagreement might have been. This is a visual that I use quite a bit, and interestingly, initially also when I have the kids pick, whenever they tell me about a particular event from the week or so, and initially they all go up to 9 or 10, say big deal, it was the biggest deal ever. But then we work on, okay, how can we make this huge deal that is at a 10 maybe come down to 9.5 or 9.8? Anything is progress. Our final area, cognitive processing style area out of the 3, is the local versus the global coherence. So a local coherence thinking style shapes the way we view the world, in that regard that we tend to be overly focused on details. Also, if we have a tendency to anyway kind of focus on negative information, then this local coherence style does shape the core beliefs pretty significantly. And then it's also a lot of times difficult to draw inferences. In general, neither one is better or worse, the local versus the global coherence processing style. However, the benefit of the global coherence is that I am able to get a bigger picture, process information for its meaning at the time, at the expense of detail, but with better understanding of the overall meaning without getting hung up on too many details. However, the local coherence style definitely also has benefits in that regard, that it's helpful with very detailed information processing, when I do visual spatial tasks, when I'm engaged in detailed drawing or identifying number patterns. And just to make my case here, I want to show you this drawing that was done by Temple Grandin. That's a hand-drawn picture that she started to complete in her teenage years. And it shows the cattle handling systems and slaughter plants that she later on became very famous for designing and revamping, and basically having cattle slaughter with a lot less stress that they previously had been exposed to, because none of these systems had been in place before she designed it. Just as a little reminder, she was born in 47, and she's really one of the very first autistic people to document the insights of personal experiences with autism. And she's a local for us, almost. She's from Boston. Interventions in regards to this type of thinking style, as please remember, the local coherence does shape the core beliefs significantly. And I have encountered many of these, such as, and I give you a few examples, I'm completely helpless is one of the core beliefs that I worked on with one of the kids. Not good enough. I'm just completely alone. I'm unwanted. I'm defective. I'm weird. These are all the core beliefs that play into the life of this child or individual. We also work with young adults and adolescents, but it doesn't matter the age. And then putting thoughts on trial is a really good strategy to address these core beliefs, the continuum technique, and then the classic cognitive model. And I show you examples for each of them. So putting thoughts on trial, this is the worksheet that is from Joel Sol's Autism Teaching Strategies website. We have that listed as one of our resources. You act as a judge. Well, your client acts as a judge with your assistance to evaluate the negative or irrational thoughts and examine them for the benefits and the disadvantage for them. So basically, it's kind of like the defense and the prosecution, and then finally on the bottom with the judge reaching a verdict that hopefully develops a more balanced and rational perspective. This is the classic cognitive model, as you're familiar with basically the thoughts. In that case, it was, I feel lazy, with the feelings triggered by the thought, tired, exhausted, lonely, and the behavior, I stayed in bed all day, I isolated, and then kind of learning to understand this kind of connection between these three dimensions, and then starting step by step in replacing them. And this is the continuum technique. Again, remember, we're trying to broaden that very localized perspective, the processing style. So we start by identifying the non-functional thought. Then we identify the opposing ends of that spectrum. For example, in this case is I'm a complete failure versus I'm a total success in everything I do. And then based on these anchors, will help to create the continuum, the gradation, and then also create a middle point, which might present the most realistic view, such as I have strength, I have weaknesses, just like everybody else, or maybe that's a real popular one I find with some of the folks I work with. I'm still a good person, even if I made a mistake. And then you support them by placing themselves along that line and gather evidence from their life to support that new perspective. So I am going to hand it back to Karen because I think maybe we have time to look at your schedule, or are we already into?
20 after. Why don't we see if there's
Okay,
any
we'll do
questions?
questions and answers then. Thank you, everybody.
All right, thank you very much for this very helpful and rich material. So before we go to Q&A, just a reminder that these rounds are accredited by the Royal College of Physicians and Surgeons of Canada and also the College of Family Physicians of Canada. And so, yeah, sometimes people take a, oh, and also please complete your evaluation form. And there's the link there and also the QR code. And our Campground Rounds Committee does look at all of the evaluations and appreciate them. So fill them in. So we'll move on to the Q&A, and just to remind people that you can raise your hand to unmute or put your question in the Q&A. And I think we have one question already by our social worker, Andrew Seeley, who asked about the Australian sensory kit that David mentioned. Was that in the list of resources?
No, but we can add it to it. Sorry about that.
Sounded really interesting.
It's online, right?
Okay, so you'll add it to your resource list and resend to Natasha.
Yep.
I'd be happy to do that, yeah.
Okay, so Natasha, did you want to unmute
Yeah,
Dr.
so
Radim?
we have Richard here who has his hand up and I've unmuted him. So go ahead, Richard.
Great. Can you guys hear me okay?
Yep.
Perfect. So hi, I'm Richard B. Thank you so much for the wonderful talk. Very informative. I'm one of the inpatient child adolescent psychiatrists here, and I would love your insight. So certainly there is a role for the hospitalization for these children for diagnostic clarification, medication review, stuff like that. But not uncommonly, unfortunately, we do in the emergency setting get these patients and families who are very overwhelmed. And again, not infrequently the frequent flyers where there's just a very low frustration tolerance, mostly to behavioral problems. So my question for you is, how can we best support these families and patients that are in obviously this constant struggle where rehospitalizations are not beneficial and unfortunately emerge in hospital can even be traumatic for these poor kids? Do you have any suggestions how we can support this patient and these patients and families to decrease those emergency presentations?
Do you want to start?
Sure. I mean, it's a great question. Actually, we are working on some research now, just looking at how well our outpatient work has done in kind of reducing rates of rehospitalization. And we know that rates of hospitalization for autistic youth are really high, sometimes like up to 5 times higher than kids in the general population. So it's not an uncommon problem. My answer is really many. I think, here at our setting, we also have a partial hospital program, which is one way to divert kids, right? It's a way where they would come just during the day. And for longer term than, say, a typical inpatient stay, but might get those kind of supports. And then we also, of course, look at home-based and other services that can provide families more intensive supports, but not necessarily bring them into the hospital. So those are just a couple of things that service-wise that I think of. I don't know if you have thoughts about sort of beyond that, but.
Yeah, we're fortunate in that we do have different levels of care, so it's not unusual at all for kids to step down to one of our partial programs, or if not that, then there's some short-term in-home services that can be provided for kids who are leaving the hospital setting. We have a lot of kids who readmit to our partial programs because the kids make such progress. It's longer, there's a lot of family work, and then families tend to drift as time goes on, and they'll say, well, I guess we need partial, and I'll try to remind them, what was it that happened in partial? It was the behavior work that you were doing, you're supporting them through crises. I think sort of if the families can be reminded of the tools they do learn either during inpatient or outpatient, then sometimes we can run interference and prevent them re-entering.
That family work is really important. That's parent stress is often a huge marker for risk of rehospitalization. So that's an important one to look at from an outpatient perspective.
And how long do these partial hospitalization programs run for typically?
Usually 6 to 8 weeks. Sometimes kids will stay as long as 3 months. And they are either, most of our programs, so we have a developmental disabilities program that has a day program for kids that's like 9 to 3. And that's for kids with a higher level of need. And then an after-school program for kids who are older and have sort of middle school and above who have verbal functioning that allows them to participate in groups. And the whole focus is self-regulation for the kids, and then working on behavioral strategies and how to support the child in their regulation strategies. The length of those programs is a luxury, and it's just a very different focus than what can be accomplished during the outpatient stay, because that really is about stabilizing the acute situation. But oftentimes there's not the luxury of a lot of family work within that setting. I'm assuming yours are similar to ours, and that inpatient is sort of get things stabilized and off you go. So they can be a week or two, sometimes longer with our population, but partial's much longer.
Yeah, I mean, currently we are lacking partial hospitalization, which we would call day program here, but we are looking to develop such a program because of the need and the gap in service. But even returning to outpatient practice, I think sometimes we all encounter, issues, even within our system of, making therapy accessible to kids on the spectrum, especially if they're lower IQ or have language difficulties. And I so appreciate you, emphasizing that we can do some, basic things like what's our sensory environment, using visuals, assessing in the moment language skills to, concretize and make therapy possible. Because I think, sometimes, traditional therapies don't necessarily, account for these accommodations. So I really appreciate, these examples that you've provided. And I think Dr. Daniel Marina DeLuca also, he's present as well. I think he's saying hi here to thank you for this wonderful presentation. And because I think you've provided your resource list, which I think many of us will, look at it. And I noticed that you've provided some training, like some sites that we can go for additional training as well, because we really want to, strengthen our ability to be able to see these, kids. And I guess maybe I just wanted to ask you, in terms of, so it sounds like you work with pretty well, like, across the age group. And so how long does your outpatient sessions typically, last for, in terms of how many, sessions?
A lot. The guidance that we got when we did peers training was you can do this training with kids with intellectual disabilities, but double the dose. So we have done that. You go longer and slower. There's just more emphasis and more practice on generalization. Well, similarly with CBT, it can take a really long time to get through sort of one of these cognitive roadblocks and work with the kid on flexibility. And then comes generalization. Can they do it outside the office? Can they do it at home? Can they do it in the hallway? So we're often with our kids for a couple of years. What we have done to kind of ameliorate our wait list is to offer the Ruby Parent Training Group. So it's we offer 6 to 8 sessions, depending on the level of functioning of the kids intellectually that the parents are parenting. And that has been really helpful in being able to take families who are on the wait list and offer them some tools that families typically find really helpful. It's a lot of the preventive strategies we talked about today, antecedent-based supports that can keep their children from having repeated problems. So I would highly recommend that, because once kids are in the clinic, they often stay a long time.
Okay, that's good to know that that realistic expectation that's going to take substantially longer, and that again emphasizing the importance of families. And we do have one last question here. This is from another child psychiatrist, Dr. Chinia. Are there recommended resources for respite programs, not just approaches, but things like recommended staffing ratios, environmental supports, etc., for kids with ASD? The rates of burnout of respite workers being afraid to work with kids who are prone to dysregulation are very high, leaving families not so well supported.
I don't know of any global resources for that. I know that here it is hard to find individual in-home providers, and when it's respite, it's often ends up being a nursing staff person. I know that the School of Nursing, I believe, at one of our local colleges offers respite every Saturday for families, so it's both a training for them as well as a lot of support through their students for children. But yeah, respite is large. It's a difficult need to fill, given all the other needs. I'll look around.
Maybe some of the Affirm and the modules, right? There are some of the online trainings that we included. Might be, and we've recommended these in schools as well for folks who are maybe not a clinician but still need some support in working with kids with autism. So there are some online trainings out there that are good resources, but yeah, it's hard.
Autism Internet Modules does talk about kids in different settings. You can select the learning modules based on that, and they may have some guidance.
Am I allowed to talk?
You're talking.
My name is, I am I was doing a substitute position for a school with a student she was supposed to be kindergarten, but her mother and her were refugees from another country, so they didn't speak English, and she was nonverbal autism. And I did, there were structured visual schedules like you showed that were, I was encouraged to use, but the teacher told me that she wanted to just keep her climatized to the classroom. So just do everything I could to keep her in the classroom with the rest of the kindergarten students. And if she started to have an outburst when I tried to keep her on the visual schedule, then to just let her do free play. She ended up, I was criticized by the speech pathologist who came in and said, "You're the adult, you shouldn't be letting her lead you around the classroom," even though and we didn't have any equipment for her because she was on a waiting list to get assessed for autism, even though she clearly had it. So I guess my question is, couldn't have she been taken to emergency and seen by a psychiatrist for the autism and be assessed for autism, so she could have at least started receiving some of the services that the agencies in Edmonton provide, like what you're providing? Because I was really struggling. Like, she ended up jumping on my back, and my back was injured, and I really tried to use all of your resources. So do you have any suggestions on how I could have done a better job?
So I hear two things. One is around the system of care. I don't know if an emergency room presentation does not guarantee an earlier evaluation. It might get you some in-home supports, but the evaluation is a chronic challenge in terms of wait lists.
Just on that note, we are hearing about some folks who are developing online virtual evaluations for autism. That, I don't know, we haven't kind of kicked the tires enough to really endorse it, but it is something that I think was meant to try to increase the availability of access to diagnostic evaluations. So that might be something to look into.
One of the groups is Catalyght, CATALIGHT. They've done a lot of research on looking at the effectiveness of online intervention evaluations. So that may be a quicker road to assessment. Around the other things, it's often about providing preventive strategies so that the child can request a break before you're forced into giving them one. So again, if giving the child a sense of agency and getting them to determine when they need a break so that we as adults don't have to wait till things have fallen apart, and then the behavior gets the consequence of avoiding the demand. I'm going to turn to our BCBA to see if she has anything to add there.
I mean, it sounds also like you've done a lot, and especially with kids on the spectrum in schools, there are so many unpredictable factors a lot of times where, it might not be realistic that she goes through the day without any kind of bumps. It's just something to probably plan for and allow her to then also kind of step out for a moment with you. Or sounds like you've done quite a bit what was just realistically doable, and unfortunately that then the system might not have supported the diagnosis for quicker services, but yeah.
Well, the other teachers were happy because she was quiet, and slowly she started to speak. She started to echo pictures that I pointed to. And so that was like, but when I returned, like, I bought her a lot of, those sensory toys that you talk about. And when I returned after my back was injured to retrieve some of my sensory stuff, the aide that they had her with had her in the hallway, had her out of the classroom. So I mean, for the entire time I was there, I kept her in the classroom. So I did do what I was told to do by the teacher, so it was like, when they talk about the least restrictive environment possible, and I myself have multiple disabilities, and yes, I've studied Temple Grandin, so like I totally understand. It's just, I think that the fact that there was a language barrier in terms of English, right, and not knowing how to speak English was a challenge for both her mother in trying to navigate the system, as well as for the child who, her mother tongue was not English.
That is another.
And I think, Anna, I really appreciate, and I think you illustrate, the multifactorial difficulties that our kids are challenged with, especially in a system with limited resources. And Yeah, I do need to close up. And so I want to again, thank all of you, Karen, David, and Kristen for actually, I think this, inspirational, presentation to inspire us to be more thoughtful and I think, a bit more hopeful about, some of the, strategies that we can use to make therapy and interventions more accessible and successful for our kids.
Thank you for having us.
Yeah, thank you for having us. It was nice to meet you. And thanks to Daniel. Bye.
Yeah, lots of thanks in the chat to you as well, if you can see that. I think much appreciated. And much to think about as well. Okay, bye.